apparently looking all the features of encephalitis, but somehow on the workup you don't get the exact cause for it. And if the patient is not improving, then the question comes for the clinician that think beyond that. Something else is there. The point which was attention drawing, that there was sudden loss of speech. Child was not able to speak at all. It turned out to be enteric fever with encephalopathy and with even the myocarditis.
Hello, thank you for tuning in. If you want to come back to this video later, just tap on the like button. It will save it to your liked videos so it's easier to find. And don't forget to hit on the bell icon to get notified whenever we drop new content. Stay curious, keep learning, and see you on the inside.
Good evening, friends. Again, I'm back to you with the new topic of encephalitis mimics. I'm sure that friends will be thinking that what we mean by the encephalitis mimics. Many times it happens in the practice that apparently looking all the features of encephalitis, but somehow on the workup you don't get the exact cause for it. And if the patient is not improving, then the question comes for the clinician that think beyond that. Something else is there looking at the encephalitis. And I think it requires a good analysis on the part of clinician and then planning for the appropriate investigations. And I'm sure that you will reach to the very unusual cause for this encephalitis-like picture. First, let us understand that what we mean by the encephalopathy and encephalitis. Encephalopathy is a very broad term in which it is characterized by diffuse cerebral dysfunction, which may be due to some toxin or the inflammation, which may be infective or non-infective in origin. So it's very simple, that it's a very broad terminology. And it's a cerebral dysfunction. It's a generalized, diffuse. And this encephalopathy, once we say it includes even hepatic encephalopathy, uremic encephalopathy, Ray's syndrome in children, Shigella encephalopathy, even viral encephalitis, autoimmune, all varieties of encephalitis, acute bacterial meningitis, and even the tuberculous meningitis. So it's a very wide spectrum. But once we say encephalitis syndrome, acute encephalitis syndrome, it's very important that we should understand that how to define. And it is defined by the WHO very appropriately that a person of any age at any time of the year presents with the acute onset of the fever and a change in the mental status. Mental status can be simply from the confusion to disorientation to inability to talk or even the coma, which usually will be the longer than 24 hours duration and or even new onset of the seizures, but it should not be the febrile seizure. This is very precise definition of encephalitis. Having this, let me take to some of the cases, which I'm sure that by the definition, it looked like the encephalitis and turns out to be something else. This was the 5 years old male child presented with very high grade fever, 100, 103 of about 2 weeks, vomiting, and even remaining sleepy recently. But the point which was attention drawing, that there was sudden loss of speech. Child was not able to speak at all. And there was no seizure. Initially treated by the family physician with Injection chloroquine, I think this is an old case when it was rampant in the practice to give the injection chloroquine. Even ofloxacin was given, amikacin was given, and even the antipyretics. There was the history of tuberculosis to the father 1 year back, and he was treated sufficiently for 6 months. Rest of the history was non-contributory. When we examined this patient, weight was 13 kg, Glasgow Coma scale was 10, that was significantly affected. Vitals, yes, very high grade fever. But pulse, look at these 56 only. That means bradycardia. Respiration rate was 20, blood pressure normal, SpO2 was maintained. There was pallor but no jaundice. Respiratory system was normal on auscultation and examination. But on cardiovascular system, as I said, significant bradycardia, when intensity of heart sounds was diminished. But there was no murmur. Liver was enlarged and even spleen was palpable. As I said, Glasgow Coma scale was 10. But signs of meningeal irritation were absent. That means no signs of meningitis. On investigations, we looked at there was a significant leukopenia. ESR, CRP, both acute phase reactants were raised. MP was negative. Mild, even hepatic enzymatic reaction. Chest X-ray normal. VSD abdomen showed hepatosplenomegaly, some lymphadenopathy, particularly the mesenteric. Blood culture urine culture were sent before starting the treatment. And this was the ECG. Friends, you can see that there is a significant bradycardia. And even somehow it was the low voltage. Having this observation, even blood culture later we got that yes, it is the Salmonella typhi. And it turned out to be enteric fever with encephalopathy and with even the myocarditis. I remember this case was seen long back, which was referred from Udaipur. And that is a very interesting story that even enteric can present with encephalopathy like manifestation as myocarditis, even the meningitis, all these complications are known, which as a clinician we should be aware of it. Let me take to you the second case. Here it was a 6 years old male child, 6 year female, present with abdominal pain and vomiting, which was going on for 2 months. Treated with the anthelmintic, antiemetic, various antacids, antispasmodics, but there was no any response to these drugs. And sonography, USG abdomen was done 3 times. Every time it was reported as normal. Nothing was there, significant. Headache now started since 10 days. And meanwhile, child developed this right side focal and then generalized seizures. Of course, seizures were controlled with the multiple anticonvulsants. That means it required even the multiple drugs. And she had post-seizures encephalopathy. That means altered sensorium. There was a diffuse cerebral function. Rest of the history we had that first born child with a non-consecutive parents without any problem. Development was normal. Even before this illness, child was absolutely normal neurology point of view. And even immunized up to the age of 5 years. No, there was history of seizures or tuberculosis in the family. And such a child was referred to us for further evaluation. When we examine, you can see that all the vitals were normal. Nutritionally, child was good. Glasgow Coma scale, yes, 15, 11 out of 15. Significant pallor was there. No jaundice, no lymphadenopathy, and no even the hepatosplenomegaly. Respiratory system and CVS were clinically essentially normal. CAS, as I said, Glasgow Coma scale was affected, but no any motor deficit, and even no signs of meningeal irritation. Investigations showed that the hemoglobin was significantly low, only 6.2. Count little bit raised with a polymorph of 75 and platelets 350,000 within normal limits. Peripheral smear was reported as hypochromic macrocytic anemia and hemoglobin was 6. That's very important point. Further workup for this anemia, iron was 21. That means iron deficiency, iron was less. Total iron binding capacity 300. Ferritin was not much affected, it was 75, in spite of your hemoglobin gone to 6. Renal functions, even the renal functions, liver functions, even coagulation profile, all these investigations were within normal limits. We did the CSF, which turned out that the protein was 65, sugar 55, cells were 20, that was lymphocytes. Gene expert for tuberculosis was negative, and CSF viral panel was done, which was also turned out to be negative. Even MRI brain was reported as normal. We didn't have any important clue that what is the problem. Meanwhile, I remember that this patient was referred to for this MRI brain, and one of my friends said that, sir, I thought something else, and I have gone for the X-ray knees. Friends, what I want your attention, you can see, particularly the X-ray knees, these epiphyses, very dense lines. And that was an important clue on the X-ray knees. We went for the further workup. Blood lead level was significantly raised, 84.53. And even blood lead levels of parents were within normal limits. So that was the case of lead encephalopathy. Then we came to know that how it has happened. Then there was traditional medicines and local applications for about 2 years for vitiligo over the lips and face. And this is known that this lead can be absorbed. I think you must be knowing that in the past when there were the pencils which was containing lead and children keeping the particular pencils in the mouth while playing, gradually this lead will be absorbed, go in the GI tract, and lead encephalopathy were reported during this time. This was a very unique case that for vitiligo, some traditional medicines must be, I would say, homeopathic medicines where metals are used, and this was the thing that how it was absorbed. And with the chronic long-term use, she presented with the lead encephalopathy, which is quite, I would say, interesting. But you know how that we are reaching to the diagnosis. Unless we go for these other thoughts, we will not be able to reach the diagnosis. Continue to think various varieties of encephalitis. Let me take you the case number 3. This was a 12-year-old female, presented illness of 9 months. 9 months problem was going on. In the pelvic fever, decreased appetite, even weight loss, and bilateral neck swellings were noted for 7 months. Initially treated with the multiple courses of oral antibiotics without any response because the lymph nodes were there. They thought of this even the lymphadenitis. There was history of tuberculosis to the grandmother 3 years back. She was treated with the 6 months anti-tuberculosis therapy. Then this child, she had to put in investigation, CBC normal, even CRP was normal. Chest X-ray was normal. Blood culture, urine culture, there was no growth. The only thing that USG showed, some hepatomegaly. And FNAC of the cervical lymph node was done for tuberculosis, which was reported as granulomatous lesion. But they didn't clarify that whether there is any cageation, calcification, or any point suggesting tuberculosis. That was just they said that it's a granulomatous lesion. Naturally, once we say in our country granuloma, always first thing comes to our mind is the tuberculosis. And therefore, she was given tuberculosis for 6 months. Unfortunately, she develops a fibrotoxicity due to anti-tubercular drug, which requires some modification, change in the treatment. But ultimately, she was treated for about 6 months for the anti-tubercular drugs. Meanwhile, now the fever spikes and intensity continue to increase. Even lymph nodes were increasing in size, cervical lymph nodes, in spite of the AKT for 6 months. And now she developed the seizures. Even somebody considered that CNS tuberculosis or anti-tubercular therapy, steroids were started, and even the aceclomide was added. And with this, she was referred to us. Friends, on examination, we found that the weight was less than third percentile. Height was not measured, but she was awake, but irritable. Even intermittent irrelevant talking. Friend, all the signs of encephalopathy. Glasgow coma scale was affected. She had mild fever, pulse 120, mild tachycardia. Mild even hypertension was noted, but SpO2 was not. There was significant pallor and mild jaundice. Multiple bilateral non-tender, soft to firm, about 2 to 2.5 centimeters in size. That means significant non-matted cervical lymphadenopathy. Abdomen was soft to distension, no ascites. Liver only 2 centimeters. And liver span was 14 centimeters. That means enlarged. It was non-tender. Spleen was also 2 centimeters in size. Respiratory system CBS were non-contributory. CNS point of view, it is irritable. Glasgow coma scale affected, but muscle tone DTR normal, and even signs of ventricular irritation were absent. Investigation showed that this count, the hemoglobin is mild anemia, count is normal, platelets significantly low. Acute phase reactants, ESR more than 100, but CRP you can see only 7. First examination showed thrombocytopenia. Bilirubin 2.8 with direct variety. SGPT and SGOTS, hundreds of enzymatic reaction. Protein albumin was low, creatinine was 1.3, that means raised. CSF examination was normal. Gerent stain with the Sibinate were negative for the tuberculosis. HIV was negative. Chest X-ray was normal. USG NIC showed the axilla, neck, axilla, and inguinal lymph nodes. It was studied by the USG and detected cervical lymphadenopathy. It was clinically also it was there. USG abdomen showed same almost enlarged liver and spleen. Rest of the investigations were within normal limits. Friends, having this, we went for this MRI brain, and which was classically reported the vasculitis. Or they said some vasculopathy. Very classical cases. And that's the thing that how we thought of. We went for the anti-nuclear antibody, which was significantly raised. When we put all the points together, that 12 years old female having the vasculitis, cervical lymphadenopathy, ESR is raised, but CRP is only normal. If you put all the points together, it's suggesting SLE. And we went for the specific investigations for SLE like dsDNA, which was significantly positive. Even the C3 and C4 complements, both were low, which is again favoring the SLE. And urine showed even the proteinuria. And therefore, creatinine was also raised. That means involvement of kidney, nephritis, any nephritis, what we say, which was classically present in this case. And that was the case of systemic lupus erythematosus. SLE. Friend, what I want to share with you, with SLE can present even with the encephalitis type picture. And unless you have this point in your mind, very easily you will miss and you will go for some other, I will say, condition or even the treatment. So this is the thing which I wanted to share with you, that we should be aware of it. Let me take to the next case. This was a 6 months female child, illness of about 7 weeks. Fever mild to moderate, then increased to high grade. Again developed the neck swelling. Child was irritable, had some conjunctivitis. Child was hospitalized and it was diagnosed as Encephalitis. Treated with antibiotics, piperacillin, tazobactam, vancomycin, matrozil. Later on, oral, even the various antibiotics were given. But the point was, high-grade fever was persistent. IV antibiotics were given through the central line. And meanwhile, child developed the convulsions and even the left side hemiparesis. And there was no any significant rest of the history. But now the child with the fever developed the seizures and developed even the left side hemiparesis. When we went for the investigations where already it was done, and which showed that yes, anemia is there, mild to moderate, WBC count is raised, leukocytosis. And you can see that every time there is a polymorphonuclear reaction. ESR above hundreds, even almost I will say 150, more than 150. CRP was above 200. And you can see the platelets sky high, thrombocytosis. That means even the leukocytosis, thrombocytosis, and acute phase reactants, both even ESR and CRP was raised. Chest X-ray showed some inhomogeneous opacity in the right upper zone. And USG neck showed the lymph node on both the sides. These were the investigations. When we examined, yes, there was high-grade fever, tachycardia, mild tachypnea, AF was open at the level, significant pallor, eyes were congested, throat was congested, no cyanosis, no interest. Just lymphadenopathy were significantly palpable. On examination, respiratory system normal, tachycardia but no murmur, liver and spleen both were palpable. Child was irritable. There was some doubtful of these seventh upper motor neuron type of paresis. And left side even the power was 3 to 4. Deep tendon reflex is brisk and no neck stiffness, that means signs of major irritation were absent. With that CSF examination, protein was raised, cells 20, lymphocytes, MRI brain was reported as normal. We went for the echo, which showed particularly that coronary is dilated, even with small aneurysm. And that was the case of Kawasaki disease with the aseptic meningitis, which was the left side hemiparesis, and that was due to the vasculitis. Friends, I'm sure that the cases which I'm sharing with you quite unusual. And unless probably we are aware of it, it's sure that very easily any person can miss the condition. Let me take you the next case. This was a 22 months old female. Fever was and cough, cold, vomiting, loose stone. So initially treated as viral infection and offered the symptomatic therapy. But third day of the illness, there was a persistent vomiting, mild fever, and child was now drowsy. Treating pediatrician referred for hospitalization for further management. It was born to the young non-conspicuous parents at full term without any problem. Birth rate was 2.8. That means whole perinatal period was uneventful and development was normal. Even child was immunized. But the point is that the child had the Kawasaki disease 10 days back. And she was hospitalized and treated with IV immunoglobulin. And of course, ecosprin tablet with even the good response. She was discharged after 5 days with even the oral ecosprin. On examination, you can see the Glasgow Coma scale is almost 7, which requires immediate intubation. Febrile, tachycardia, tachypnea, SpO2 was maintained. Blood pressure okay. Respiratory system CVS normal except mild tachycardia. Liver was enlarged, spleen was not palpable. In Glasgow Coma scale, as I said, and there was a hypotonia, significant hypotonia. Again, on examination, investigations. Hemoglobin was okay, count was okay, CRP was normal, platelets normal, sugar and creatinine, sorry, that is the platelets, by mistake it is creatinine. EBG and electrolytes were normal, bilirubin normal, but SGPT and SGOT raised. PT you can see that 35 by 50. That means PT is prolonged. INR was 1.8. Even APTT was prolonged. That means PT and APT both are prolonged. And that gives the idea that this is the liver problem. Somehow CSF was totally normal. CT scan of brain was diffuse cortical swelling and plasma ammonia showed more than 200. And that was the case of Ray's syndrome. Fortunately, nowadays it has come down with the probably routine use of the aspirin has been stopped for the fever. But yes, it is there. And particularly when the child is on aspirin, this viral infection can precipitate Ray's syndrome, particularly the viruses which are known to create this problem, Coxsackie and others. Friends, I was not aware that how this Kawasaki and Ray's syndrome is having the connection. We refer the literature. We got the answer that yes, Ray's syndrome arising from the treatment of Kawasaki disease is reported by somebody else. Even Kawasaki disease with the Ray's syndrome, that was reported as a one case. Also, we check in the literature. We got the multiple reportings by other friends. And friends, that's the thing. That's how we got that. Yes, it is known in the literature. Friends, with these some illustrations which I wanted to share with you, that clinically, absolutely mimicking like encephalitis. But once you don't get that, it is not the Japanese encephalitis. It is not the herpes simplex encephalitis. It is not any autoimmune disease. Even not this any type of the meningitis. Go for the lateral thinkings. And that can be the various conditions as I talked to you. Maybe the hepatic encephalopathy, even the salmonella encephalopathy, even seizure encephalopathy, various toxin can cause, and that we should keep in mind. Thank you very much. Thanks a lot.
Thank you for yet another enlightening talk. We'll just allow a moment to our doctors. If anyone has any questions, kindly put it up in the comment box. We will get started with the Q&A now. So Dr. Ekta asked, most common drug of choice for encephalitis?
Most common drug of choice for encephalitis. I think you know that we'll have to first know that what type of encephalitis. Most common we get is the viral encephalitis. And you know, most of for the viral antivirals, we have the very few drugs. But please keep in mind that if you have diagnosed viral encephalitis, that is a sporadic, particularly herpes simplex encephalitis. Herpes simplex encephalitis is a treatable cause for the encephalitis. And that can be confirmed, the diagnosis, by CSF PCR. That you do the CSF PCR. Initially, suppose if you have done maybe the negative, you repeat it after even the 48 hours or so, and many times it may be negative, but maybe positive. So once you come to the conclusion that it is herpes simplex encephalitis, drug of the choice is aceclomide. And aceclomide should be given in 10 milligram per kilogram per day, and that is should be continued for 3 weeks duration at the intravenous. That is very important. The newborn, the dose is 20 milligram per kilogram per day. But suppose Japanese encephalitis or varicella encephalitis or even Epstein-Barr or some other viral encephalitis, we can go for just symptomatic treatment. There is no any specific drug. But yes, for the herpes simplex, and suppose if you are not able to confirm the diagnosis, consider herpes simplex and give the treatment with the aceclomide for 3 weeks.
Moving on to the next question from Dr. Jitendra. How aspirin causes Ray's syndrome?
Exactly, aspirin is a predisposing factor, it's not the direct responsible cause. But you know, aspirin is known to cause the hepatocyte damage. And when particularly the child is exposed to any virus, and this situation, if the aspirin is given, it is, I would say, precipitating factor for the Ray's syndrome. Directly, aspirin does not cause this Ray's syndrome. particularly following varicella infection and aspirate is common.
So the next question from Dr. Nitin, differential diagnosis of encephalitis.
Today I talked to that encephalitis is very wide terminology. It can be even the viral origin, which is most common, can be even acute bacterial meningitis, tuberculous meningitis, even the various metabolic causes like varicella. Earlier I was talking the hepatic encephalopathy, uremic encephalopathy, even salmonella, shigella. So many conditions are there. And for every condition, there is some clinical history and examination. Or even specific investigations, we can go for the confirmation of diagnosis. But these are the differentials. And most common viral encephalitis, I think, as a clinician, we should keep in mind that if it is a really epidemic, that is Japanese encephalitis, which is somehow fortunately less common or hardly seen in Gujarat. But some of our states, particularly if I say Tamil Nadu, even eastern part of our country, some part of Uttar Pradesh, Bihar, even the part of the West Bengal. In these parts, this Japanese encephalitis vaccine is very common. Government of India has identified even some districts, some hundreds of districts where Japanese encephalitis is common. And the point is now, we have the very effective vaccine for the Japanese encephalitis that we should use. And of course, even the herpes simplex, as I said, even nowadays, various varieties of Chandipura viral encephalitis, Nipah, even the encephalitis, Zika encephalitis. So all these types of the viral encephalitis we do come across.
So the next question from Dr. Jain. Is there any algorithm for following the different differentials for encephalitis?
Yes. Very good algorithm is there for differential diagnosis and even the treatment. WHO has given. I think like sometime I will share in this group. It is there.
So Dr. Deepesh asks, how traditional medicine cause lead encephalopathy?
The medicines, they don't cause these traditional medicines also, they don't cause the encephalopathy. But that basically they are the metals. And metals are deposited in various parts of the organs. Even it can be deposited in liver, which will cause the cirrhosis of liver. It can deposit in the kidneys. It can lead to the kidney failure. Even it can lead into some parts of the brain. Support lead. It can cause the lead encephalopathy. So that medicine, what are the contents? Particularly this alternative medicine or homeopathic medicines, it is based on the heavy metals. These metals will be absorbed, will be deposited in the brain, which will cause the encephalitis like picture, I will say. Therefore, I will say encephalitis mimics. It is mimicking like encephalitis. But it is due to the particularly heavy metal poisoning or toxic.
Dr. Moria asks, a role of steroid in encephalitis.
Not all, but certain, yes. Suppose I will say herpes simplex encephalitis, we don't go for that. But at the same time, tuberculous meningitis, yes. Or any particularly for this raised intracranial pressure, we may use it. But routinely, I will say, not all the patients which we are doing in the past.
Dr. Rahman asks, CNS tuberculosis, if you could give a brief information.
CNS tuberculosis is very large, I will say, subject and chapter. It can cause the various, I will say, varieties of presentation. It can cause the simple tuberculous meningitis, with even the protobal symptoms. And if you go for even the further investigation CSF, you may get even the CSF picture suggesting tuberculous meningitis in the form of the raised protein, lymphocytes. If you go to the gene expert, even you may get positive. Sometimes it can be even the just tuberculomas, which will be detected on the CT or MRI brain. Even it can cause the CSF circulation obstruction, and that was present with the obstructive hydrocephalus. Even it can cause these tuberculin encephalitis. Even it can cause these various type of the endocrine disorders occasionally, that even the precocious puberty and various, because there can be involvement of the pituitary gland. So there are the, I would say, varieties of these CNS presentations, which we can keep in mind.
So thank you for taking our questions from our doctors, sir. There's another question from Dr. Mohammed. What has your experience been with non-MTB?
Yes, atypical mycobacteria or non-tuberculous mycobacteria. We do come across in the practice. Not I will say routinely, but sometimes yes. If somebody asks me that, yes, I've seen the patient. Commonly they present as these subcutaneous lymphadenopathy. If you go for the biopsy, you may get the Jared stain, AB positive, or even the histopathologically granulomatous disease. But if you go for the gene expert is negative. Because gene expert is very specific PCR test for the Mycobacterium tuberculosis complex, which is typical mycobacteria. So non-tuberculous mycobacteria, Jared stain may be the positive, or even you can see the acid fast bacilli, or even the granulomatous disease on histopathology, but gene expert is negative. And usually these patients may not have the all constitutional symptoms in the form of fever, decreased appetite, weight loss, may not be there. But just lymphadenopathy or some ulcer, and then once you go for the investigations, you may come across, and yes, atypical mycobacteria. And they non-tuberculous mycobacteria are present everywhere. It is present on your table, even on your, I would say, mobile. And once there is some, I would say, breach over the skin, and this bacteria comes in the contact, it can cause the disease. So yes, this is known, and in the practice, not I will say so common, but yes, we do come across, we get the cases. The treatment is different, so that should be diagnosed properly. Our routine anti-tumor drugs may not work. Sometimes even just you can remove the surgical lymph node, may not be the anti-tumor drugs may be required. And sometimes, yes, it should be treated.
So, Dr. Upadhyay asks, treatment for encephalitis caused by enteric fever.
Treat the enteric fever, and even the encephalitis symptomatic point of view, patient will recover. That is the step triaxone you can treat it. And with this response, the patient recovers, fully recovers. I have seen multiple patients.
So that is it for the questions. So thank you so much for taking in the questions from our doctors. Thank you once again for this wonderful session. It's always a great time learning from you, and hopefully we'll see you again soon on Medflix. So thank you once again for this wonderful session.
Thank you very much to all the, I will say, viewers, and even the specifically Varsha, that in spite of some technical issues in our presentation, efficiently she is able to manage. Thank you very much for inviting me and giving this opportunity. Thank you very much, and good night. Good night to all.